Hello everyone, welcome to Patho Excellence. In this lymph node cytology video series, today we are going to discuss lymph node cells in cytology and their diagnostic significance. So let's start. So topic outline is, today we see first of all basic lymph node compartments that we have already discussed in detail in previous lecture, but we will revise here. Second, disease entity that can be found in lymph node fine needle aspiration cytology, importance of lymph node FNAC, FNAC technique and stains, and how B and T cell differentiate in lymph node and lymph node cytology in detail. And in last, there is a last minute revision slide so that you can easily remember before your exam. So let's revise. So basically, in our previous video, we have discussed what is actually a histological appearance of lymph node. So here you can see this is the lymph node capsule, and beneath this subcapsular sinus, these are lymphoid follicles which is residing in cortex. Then beneath the cortex, this is paracortex and medulla, and here you can see this is the sinus, and these are the afferent and this is the efferent lymphatics. So capsule, then cortex which is B cell area, paracortex which is T cell area, and medulla which is containing mainly plasma cells and macrophages. Now, as we all know, there are different types of disease, and we can easily diagnose with the help of lymph node FNAC cytology. And all these disease, if we categorize, there are benign, malignant and metastatic. So 90% of lymph node lesions are of benign type. Among these, 60% are reactive hypoplasia, and if we see 30% in this category, these are Kikuchi's disease, tuberculosis, rheumatoid arthritis, infectious mononucleosis, SLE, toxoplasmosis, HIV, and phenytoin reaction. Malignant lesions are mainly nodal lymphomas, which are of 3%, and they are DLBCL, follicular lymphoma, mantle cell, PTCL, and Hodgkin's lymphoma. While metastatic is comprising of 7% of total, and there are different types of malignant lesion can metastasize to lymph node. Now, what is the importance of lymph node FNAC? So, it is the first investigation in a patient with a lymphadenopathy because it is minimally invasive, quick, cost effective, OPD based procedure and safe with very low complication rate, and it helps avoid unnecessary excisional biopsy in many benign cases. So what exactly we need is needle syringe. Some may have pistol handle, so it helps in creating excellent pressure, and we require 22 to 23 gauge needle, 10 ml syringe, and during this procedure multiple passes are required according to the size, and we must avoid excessive suction in suspected lymphoma because it may damage lymphoid cells, and we have to prepare multiple smears. So uh, in the procedure, first of all we have to see the palpable lesion, and with the help of clinical history uh, we can get some idea about the lymph node pathology. So once we decide the exact location of lymph node, we have to trap between thumb and forefinger, and we have to introduce the needle. Now redirect the needle by moving it in, out and through, and nodal in the several times until when looking into needle hub, a tiny bleb is apparent within the needle's inner circumference. So, hemodilution is avoided with this step. So, once we get material, we have to follow some technique which is for the high quality diagnostic slides preparation. So, attach an air-filled syringe to needle and expel only half drop from the needle onto each of 2 to 3 slides, which keeps each slide sample the right consistency, avoiding preparation that are too thick. And gently lay a clean side crosswise on the droplet, allowing it to break the surface tension. See, too much pressure if is given during the spreading of the material, it will damage the lympho cells. So, while holding the slide on both hands with the free hand, gently pull the spreading slide across the aspirate slide, and which allows good smearing of the droplets. And see, this is how you have taken a small drop of material on the slide with gentle pressure, make a good smear. And now after you make the different smears, we require two types of smear. One is air dried smear and second is alcohol fixed smear. And if you have enough material, you can make cell block preparation, and if you suspect lymphoma, you can collect sample for flow cytometry also. Now, what are the different stains we use generally for the air dried smear? It is May Grunwald Gimsa or MGG stain, Gimsa stain and Leishman stain, alcohol fixed slide, which is PAP stain and hematoxylin and eosin, and some special stains are required. Then it is for the tuberculosis, Gel and Nelson, PAS stain, reticulin stain or IHC for cell block. Now, why we require this different types of stain in each lesion? So, if we do Gimsa stain or MGG stain, it gives cytoplasmic detail and we can easily identify lymphoglandular bodies. So, what is a lymphoglandular bodies? That we will discuss in later on. Now, PAP stain will give us excellent nuclear details. HNE, which is architectural impression, is easy with this cell, this stain. ZN for acid fast bacilli to detect tuberculosis, and PAS for fungal organisms. Now, when we aspirate a lymph node, these lymph nodes are truly not normal lymph node, because normal lymph nodes are very small and we cannot palpate it. So, they are reactive lymph node that we are able to palpate, and we can aspirate from that palpable mass. So, most normal but enlarged lymph nodes are of hypoplasia, and in which various cellular components of a normal nodes are increased. So, when we aspirate lymphoid tissue, two consistent findings are there. One is a dispersed cell pattern and second is lymphoglandular bodies. So, basically lymph node cytology is comprising of different types of lymphocytes, right? So, small mature lymphocytes is covering 80 to 90% part of total cell population of lymph node, right? So, lymph node cytology, when we see, it is of polymorphous population comprising of small lymphocytes, plasmacytoid lymphocytes, centroblast, centrocytes, and immunoblast, uh, tingible body macrophages, sinus histiocytes, dendritic cells, dendritic lymphocytic aggregates, intact means intact follicles, endothelial lining, eosinophils, mast cells, neutrophils, and plasma cells. So, how you identify all the cells? So, let us discuss in detail. So, basically, when you get these different types of cell, you can have some idea that if you are having excessive numbers of small lymphocytes, you can be in the primary follicle. So, it contains small B cells. Germinal center, it contains centroblasts and centrocytes as well as follicular dendritic cells, and its cytological pattern is polymorphous. Mantle zone. So, mantle zone comprising of small IgM positive B cells, and they are uniform small cells. Marginal zone contain mammary B cells, they are monocytoid cells. Paracortex is T cell zone where you find T cell, T lymphocytes and interdigitating cell. And you find immunoblast in viral infection. And if your needle is in medulla, excessive amount or excessive number of plasma cells you can identify in this region. So, now why these different categories or different types of cells are there? So, how they mature or how they differentiate? Let's see in this diagram. So, if you understand this diagram or differentiation pathway, you can easily identify centroblast, centrocyte, and its what is the significance behind this increased number of these cells in cytology. You can judge, right? So, let's see origin, function, and dynamics of these cells. So, you all know all lymphoid cells origin in the bone marrow. Now, the B cell mature in the bone marrow and the T cell migrate to the thymus where they differentiate further. Now, from the bone marrow and thymus, the cell colonize the secondary lymphoid organ, which include the lymph node, spleen, and mucosa associated lymphoid tissue. The immune response takes place in this organ. Now, in an early B cell reaction, so these are the naive B cell from the primary lymphoid follicles in the cortex are transformed into IgM blast, right, in the paracortex, right. So, they are transformed in the IgM blast. Now, this cell may enter into the follicle to initiate the formation of germinal center. So, they are entering into the follicle and they may differentiate into IgM secreting plasma cells also, right. So, some of the cells going to follicle to make germinal center and some of them may going to medulla where they become they become plasma immunoblast, right. Now, after this cells reaching to the germinal center, the germinal center formation begins with the entry of this IgM blast into primary follicle to form centroblast, right. So, as the proliferation continues, centroblast migrate to more peripheral zone. So, here you can identify these are the cell going to mantle zone. From they entering into the dark zone of this germinal center where they proliferation continues and centroblasts migrate to a more peripheral zone of the germinal center to become immunoglobulin secreting centrocytes, right. So, these are the B blast, they are in the dark zone, they are going to light zone and they become centrocyte. Here already the these follicular dendritic cells, they are antigenic presenting cells are present, they will help with the secreting cytokines to make this reaction for infection, right? Now, after this centrocyte may become memory cell and reside in the mantle zone around this germinal center, or may leave germinal center to form marginal zone around the periphery of this mantle zone, right? So either they live in the mantle or they live and going to marginal zone. Now from this they converted into monocytoid cell, and finally they can be converted into plasma blast and plasma cell that ultimately migrate into the medullary area, right? Now all naive cells or inactive cells, centroblasts, centrocytes, mantle zone, marginal zone, right? They all express pan B cell marker CD19, 20, 22 and CD79A. And centroblast and centrocyte express CD10 also. So primary follicles and mantle zone lymphocytes express CD5 as well as IgM blast, right? So before activation and mantle zone. So up to here, these cells are positive for CD5, right? So naive cells as well as cells in the mantle zone. Now the T cell. So the T cell enter the lymph node via the endothelial venule, right? So they are here differentiated into lymphoblast. They are naive T cells CD4 and CD8. They enter into the lymph node and they present in the paracortex. Here they become T cell immunoblast, and few T cells are also present in the this follicle, right? So this T cell help B blast, means centroblast and centrocyte for the its function, as well as FDC or follicular dendritic cells are also necessary for germinal cell function. Now T lymphocyte express CD2, CD3, CD5 and CD7. So depending on the membrane glycoprotein, they belong to the CD4 or CD8. Their CD4 is helper cells and CD8 is suppressors, or they become or converted into natural killer cells. So basically small lymphocytes going to paracortex with the antigenic stimulation, this IgM blast converted into centroblast go converted into centrocyte. In the light zone, they reside either in the mantle or marginal zone, converted into monocytoid, or finally in the plasma cell. So when you aspirate lymph node, you can have these different types of cells starting from small lymphocytes to centroblast, centrocyte, monocytoid cell, plasma cells and immunoblast, along with this antigen producing antigen presenting cells, follicular dendritic cells. So this is very important to understand, because depending on the number of the cells, you can have judgment that your needle is in germinal center or in the paracortical or medullary area. So now let's see now how you identify all the different types of cells of lymph nodes. So let's see one by one. So first of all, we have to differentiate the size of the cell according to which we can put that particular cell in some category. So we can divide either as a small, intermediate or large cell. So small is 6 to 12 micrometer. Now how to judge? So you have to compare RBC which is present in your aspiration. The small cells are less than or equal to 2 times RBC and they are naive or inactivated lymphocytes. Now in intermediate cells, so these are centrocytes and some of the centroblasts. So they are 2 to 3 times of RBC, 12 to 20 micron size, and large cells, they are more than 20 micron and they are more than 3 times of RBC size. So these are immunoblast and some centroblast, right? So basically you have to use RBC in your smear as an internal size control. And you may also divide the cells which is given in this cytology book, either cleaved or non-cleaved cells. So small lymphocytes, these are comparable with the RBC size. Now small cleaved cells and large cleaved cells. So small cleaved cells, as we have already discussed, they are larger, slightly larger than small mature lymphocytes. Like large cleaved cells, which is having cleft in the nucleus, they are up to 3 times of the size of the small lymphocytes. And because of cleft, they are called cleaved. Now, small non-cleaved cells. So, they are mitotically active and nucleus is twice the size of lymphocytes or same as the histiocytic nucleus. So here you can take compare rule cell this as a ruler is histiocyte also, and large non-cleaved. So it is having nucleus 3 to 4 times large size of lymphocytes, and if we see they are round to oval and more than 2 or 2 to 3 nucleoli usually at the nuclear membrane. So this is large non-cleaved, basically it is centroblast. And immunoblast, it is the cell large non-cleaved, deep basophilic cytoplasm and having a irregular nuclear membrane and having a single prominent nucleoli. Plasma cells, as we know, it is eccentrically placed nucleus and perinuclear half. Tingible body macrophages, which this is a histiocyte with ingested material, and it is 1 to 1.5 times of red cells. Cytoplasm is pale, abundant, or sometimes vacuolated. So these are the cytology in diagrammatic way. So these are inactive cells, large cells with prominent 3 nucleoli residing at the nuclear membrane. Cleaved cells are centrocytes. Immunoblasts are large cells with prominent single centrally placed nucleus. Plasmablast, large cell with prominent nucleoli, and plasma cell having cartwheel appearance of nucleus, perinuclear half. So here you can see this is perinuclear half and in the cartwheel appearance of the nucleus of plasma cells. These are the centrocytes which is having cleaved. Centroblast identified by the prominent nucleoli. Small cells, compact nuclei is small lymphocytes or naive B cells. Immunoblast having a centrally placed nucleus, and here it is not appreciable, but we will see in next section where you can identify it easily. So either you classify as a small, intermediate or large cell, or you classified as a small non-cleaved, cleaved cells also. So this is small non-cleaved cells having regular nuclear membrane. Large non-cleaved, these are centroblast, 3 nucleoli and fine chromatin, right? Now cleaved cell which is having cleft. So centrocytes having cleft with visible small nucleoli, and this is small cleaved cells. This is large, this is small, and this is also again a centrocyte. And here immunoblast having a basophilic cytoplasm with centrally placed nucleus. So these are the small round lymphocytes, cytologically dense coarse chromatin. So this is comparable with the RBC. So this is the RBC. You can have look here. These are the dark compact coarse chromatin. These are the small lymphocytes. So these are the small lymphocytes, no nucleoli and very small rim of the cytoplasm, right? So these are the dark nucleus, and they are located mainly at the paracortex, mantle zone and medullary cords. Here you can compare this large cell with these small cells. This is centroblast, uh, round regular nuclear membrane and visible three nucleoli and abundant cytoplasm. And these are the cleaved cells, large and there is small lymphocytes and having a cleft. So these are the centrocyte. So where you find small lymphocytes? Mostly in the resolving reactive hypoplasia, uh, CLL, BCLL or small lymphocytic lymphoma, mantle cell lymphoma, lymphoplasmacytic or Hodgkin's lymphoma. And uh, it is having significance because resolving is benign in nature. If it is CLL, it is monomorphic. In mantle cell lymphoma, there are presence of intermediate cells along with this. Lymphoplasmacytic, you can find small lymphocyte along with the plasma cells, and Hodgkin's lymphoma where you find Hodgkin cells but the background shows small lymphocytes. Now intermediate size lymphocytes, or you can say centrocytes mainly and few centroblasts. They are having nuclear irregularity because it is having cleaved nuclei, more open chromatin, moderate cytoplasm, and mainly seen in mantle cell lymphoma, marginal zone lymphoma, peripheral T cell lymphoma, Burkitt's, and precursor lymphomas. So you have to see pattern as well as monomorphism because it is important for lymphoma diagnosis. So here you can see these are the small lymphocytes, small in size. These are the cleaved nuclei of intermediate cells are centrocytes. So these are the intermediate size centrocytes, and you can compare these are the large cell centroblast. And this is a follicular dendritic cell. We will discuss in next slide. So now monocytoid B cells. So these are oval bean-shaped nucleus, pale abundant cytoplasm, intermediate size and mostly accumulate in lymph node sinuses. They are CD20 and 19 positive. So these monocytoid B cells are seen in the mainly marginal zone lymphoma. So marginal zone lymphoma contains these monocytoid B cells. And in reactive conditions like toxoplasmosis, cytomegalovirus infection or early HIV or cat scratch disease may show this monocytoid B cell proliferation. Now let's see in detail centrocytes and centroblasts. So centrocytes, they are having cleaved nuclei, no nuclei or very small nucleoli, right? And they are surface immunoglobulin positive IgG as well as IgA positive. Now centroblasts, they are large, 1 to 3 peripheral nucleoli and moderate cytoplasm. So here this is the pap stain. You can see centroblast very beautifully seen 3 nucleoli attached to this nuclear membrane, right? So this is centroblast. So now you appreciate these are the small lymphocytes. These are the cleaved centrocytes. So here you can appreciate these are the cleaved large and this is the small cleaved centrocyte, right? So centroblast, open chromatin, nucleoli, these are the small lymphocytes, these are the cleaved small, cleaved large centrocytes, right? And these are the follicular dendritic cells, right? Here also you can see large cell, centroblast, cleaved centrocyte which is large in size. Yes, it is difficult to differentiate B and T cells in lymph node cytology, but some of the books say that if the cell having cytoplasmic process, they are mostly of T cell type, but we cannot judge in each and every case. So if you have a lymphocyte with cytoplasmic process like this, it may be T cell type, right? So B cell and T cell, it is difficult to differentiate. And here this is the capillary or endothelial cells, endothelial lining, right? And here this is the follicular dendritic cell. Now, what is the significance of these follicular center cells? When you find mixture of centroblast, centrocyte, small lymphocytes, they in reactive condition, mostly in the reactive hypoplasia, syphilis, then you can find this along with the plasma cells. In early HIV and Castleman's disease, you find follicular center cell. So, centroblast and centrocyte, as the name suggests, because they are residing into the germinal center. So from the center, centroblast and centrocyte. And in malignant condition, follicular lymphoma, DLBCL and peripheral T cell lymphoma. So whenever you find mixture of all the cells, polymorphous population, so it is indicating reactive condition. But in case of lymphoma, there is monomorphic cleaved cells are generally present. So, monomorphic population suspect lymphoma, polymorphic mostly reactive. Now, another is plasmacytoid lymphocyte. So, we have seen small lymphocyte, cleaved and non-cleaved or centrocyte and centroblast. Now, let's see what is plasmacytoid cells. So, they are located at the junction of paracortex and medullary cords and typically show ill-defined cell border, pale cytoplasm, round to pale, slightly larger than small lymphocytes and mostly seen in Kikuchi Castleman disease in which hyaline vascular variant show this type of plasmacytoid lymphocytes. Now, immunoblasts. So, they are immunoblast, mostly it is a paracortex cell. It is largest lymphoid cell, prominent nucleoli and deep basophilic cytoplasm, right? So here you can appreciate, see, all these cells having a light blue cytoplasm and largest cell of the this smear and having deep blue cytoplasm. So this is immunoblast and this is also a large cell, but here you can appreciate having a light blue cytoplasm. Yes, here you cannot appreciate nucleoli clearly, but this is a centroblast. Here also this is a centroblast. This is small lymphocyte here and these are the cleaved cell, right? So this is centrocyte and centroblast. Now immunoblast may mimic Reed-Sternberg cell, so we have to be careful when we see excessive number of immunoblasts. And in reactive condition, most commonest diagnosis or most commonest cause where you find multiple or excessive number of immunoblasts, which is infectious mononucleosis. Some drug reaction, vaccination, or appendicitis nodes can have this increased number of immunoblasts. And immunoblastic lymphoma and PTCL also show malignant this immunoblast increasing number. Now, what is follicular dendritic cells? These are the very important cells because they are antigen presenting cells. They present this antigen by capturing in their cytoplasmic process to B cells, and with this along with the cytokine production from these FDCs, they form a germinal center, and this actual pathway of B and T cell activation will be there for the immunological response. So how you identify? So having a here you can identify this elongated cytoplasmic process, pale irregular elongated nucleus. You may have bi or trinucleated. You may find nuclear molding, and sometimes if without cytoplasm, if it is present, it may mimic epithelioid cells. So here, so you can appreciate this is the cytoplasmic process having round to oval nucleus. Sometimes you may find prominent central nucleoli, and CD21, CD35, CD23 and S100 positive, and mostly it is seen in malignancy like Hodgkin's lymphoma, Castleman disease, and in malignant form FDC or follicular dendritic cell sarcoma may show this type of cells. So here in this diagram you can appreciate now centroblast, centrocyte, dark small lymphocytes, and these are the follicular dendritic cells. So pale nuclei, some round to oval shape, and yes, it is having one flat surface. So one surface is flat and another is convex. So this is identification mark, pale nuclei, elongated or cytoplasmic process, one surface having flat surface, or it is round to oval in shape. Another important feature for this identification of follicular dendritic cell is that they form a part of germinal center fragments and mix with numerous reactive lymphocytes, and they are large cells with ill-defined cytoplasmic border, and sometimes it may be present in the syncytium, right? And nuclei are round to slightly oval with sometimes binucleation, and that shows molding. So this is called kissing pattern. So they are generally seen as in a pair, right? So this is called kissing pattern, and when along with this excessive number of these follicular dendritic cells, endothelial fragment and attached lymphocyte, it is called dendritic lymphocytic aggregate or intact follicle. So one important question is that why when you aspirate any lesion, any carcinoma, you find a cell in a cluster or in a sheet or group. But when you aspirate lymph node, you will find most of the cells are singly scattered. Why? Because lymph node is having very low amount of stromal component. So when you aspirate, these cells are easily uh, dispersible. So cells are singly scattered because of low stroma. But still, when their lymph node are activated or germinal centers are there, these follicular dendritic cells are increased. They are stromal in origin. They are part of this mesenchymal component of lymph node, and they form this aggregate, and you can find these intact follicles in this condition. So these are the aggregates of lymphocytes adherent to follicular dendritic cells and mostly present in follicular hyperplasia and follicular lymphoma. And some of the non-lymphoid tumors like malignant melanoma, which lack cohesion, and sometimes it may mimic as malignant lymphoma. Now, second is again a reticular cell or interdigitating dendritic cells. They are present in the paracortex, and they are large, irregular folded nucleus with pale cytoplasm. It is very difficult to identify. They are HLA-DR positive, S100 and CD1A positive. Mostly seen is in the interdigitating dendritic cell sarcoma and in reactive like dermatopathic lymphadenopathy. So we require IHC to identify this dendritic cells. If it is in large number, we can identify. Now histiocytes. They are large cells, vacuolated cytoplasm, CD68 and lysosome positive, and mostly seen in the samples from germinal center. So here you can identify this is the tingible body macrophage having vacuolated cytoplasm, and here you can identify nuclear debris in the cytoplasm and large to round to oval nucleus. And different types of or special forms are like one is tingible body macrophage, second is epithelioid cells which is slipper shape or mainly seen in the tuberculosis. Emperipolesis, this is seen in rhozoid often. So if you see pattern non-necrotizing granuloma with epithelioid cells, it is sarcoidosis. Necrotizing granuloma in TB and fungi. Emperipolesis in the rhozoid orphan, Fomi in Whipple's, and crescentic histiocyte, which is the characteristic of Kikuchi's disease. So this table shows cytological patterns of histiocytes in different types of diseases and conditions, and these are the clue here given for identification and for the diagnosis of different diseases. So I am not going in detail, but you should remember epithelioid cells, some lipid-laden histiocytes in the hereditary storage disease, starry sky appearance in the high-grade non-Hodgkin's lymphoma, which is due to presence of tingible body macrophages, right? Crescentic in Kikuchi's lesion, then sarcoidosis where without necrosis granuloma is identifiable, syphilis having non-necrotizing blood, abundance of plasma cells, leprosy which is having foamy macrophages but you can identify with this acidified stain, Whipple's disease which is pars positive granules in the macrophages, and Hodgkin's lymphoma where granuloma along with the RS cells. Langerhans cells, CD1 and CD100 positive. So these are the cells. And yes, rhozoid orphan disease which is engulf intact lymphocyte which is called emperipolesis, and there is large histiocyte. So here you can see this is a emperipolesis. So this is the actual nucleus of this histiocyte, and these are the engulfed lymphocytes in this cell. So this is a emperipolysis in the roside orphan disease, and here these are the epithelioid cell granuloma, where you can identify this is the epithelioid cells which is having a sleeper shape. Now plasma cells. So plasma cells having eccentric nucleus, perinuclear half. They are CD138 positive. Mostly in abundance it is primary and secondary syphilis. Then Castleman disease and rheumatoid arthritis, where you find numerous plasma cells. Dermatopathic lymphadenopathy, SLE, roside orphan, Kimura, late and chronic HIV lymphadenitis, lymph node involvement of cutaneous T-cell lymphoma, Sézary syndrome. All these shows increased number of plasma cells. But if you remember some a name, mostly syphilis, Castleman, rheumatoid arthritis. Castleman is of many types, but plasma cell types is showing plasma cells. Neoplastic condition, where you find increased amount of plasma cells, are myeloma, multiple myeloma, lymphoplasmacytic lymphoma, and marginal zone lymphoma. And now mast cells. So mast cells, they are large black granules containing cell. They are seen in Kimura's disease, mastocytosis, and reactive hypoplasia. Eosinophils in allergy, Kimura disease, and drug reaction, and infectious mononucleosis, where you find eosinophils. And in Hodgkin's lymphoma, PTCL and CTCL, you will find this eosinophil in abundant number. Neutrophil seen in acute bacterial lymphadenitis, Cat's disease, Kikuchi and Hodgkin's lymphoma. Lymphoglandular bodies, which is nothing but the cytoplasmic fragment of these cells. They are 2 to 10 micron in size, and it suggests lymphoid origin, numerous in lymphoma. They help differentiate from carcinoma, and 14% of non-Hodgkin's lymphoma may show few lymphoglandular bodies. So basically this last slide is a complete revision of your all lymph node cytology, where you can find which cell in which compartment, which key IHC marker is important, and which is the condition where you find in excess, and which neoplastic condition shows this type of the cells. So basically, if you want to uh, uh, see these lymphoglandular bodies, here you can find these are the cytoplasmic uh, processes or fragments, right? So they are very much appreciable in Giemsa stain, and also in the pap stain you can find these are the cytoplasmic fragments. So these are lymphoglandular bodies, and it suggests the smear is from lymphoid origin, right? So this is about lymph node cell cytology, and in next video we will see reactive lymph node cytology approach in detail for different types of diseases. So if you haven't yet subscribed this channel, please like, share and subscribe this channel for more such video, and you will enjoy lymph node cytology. And when you do microscopy, you will be able to identify all the different types of cells easily. So thank you for listening. Have a nice day.